Let's go. My name is Dr. MarkAlain Dery. I'm the Medical Director of Infectious Diseases and Chief Innovation Officer for Access Health Louisiana. I live in Louisiana. I live in New Orleans, Louisiana. And I serve as co-chair for the ACOI Infectious Diseases Subspecialty Section. You see me do these updates now for over a year. Crazy. In conjunction with the leadership of the ACOI. Hello, leadership of the ACOI. Thank you for letting me do these videos. I hope these messages are helping you keep up with the latest COVID-19. I know many of you are in the thick of the fight. I'd like to thank all of you on behalf of all of us here at the ACOI and those that do infectious diseases for a living. Thank you so much. Also, on behalf of the ACOI, I need to ask you, are you registered yet for ACOI virtual spring meetings? I'm speaking at it. There are 3 meetings coming up. I'm speaking at 4. I'm doing 3 lectures at one and then one at another. You do the math. Anyway, from early May, from May 11th to the 15th, and they're focusing on 3 important areas, all with an opportunity to earn much needed CME credits. We need plenty of those, don't we? So check them out on the ACOI website. And guess what? If you register before April 20th, there's a watch, which is in like a couple of days, so you still have time. You get an early bird discount for the meeting, and you get $100 off. 100 smackaroos off the ACOI Convention Center and Scientific Sessions. And speaking of the annual convention, stay tuned for more information. They will be announced shortly. Please, let's go to San Francisco and do this in person. Vaccinated, so we can all go. It'd be awesome. I can't wait to see all y'all there. All right, so moving forward together with the ACOI, we'll continue to share information as it becomes available and some of the hopeful progress that we see along the way. All right, just as the momentum for vaccine is picking up and the country is getting vaccinated at a rate of 3 million vaccines a day, along comes an announcement this past week that the Johnson & Johnson vaccine is being implicated in fatal blood clots in women for the ages of 18 over 48. There were 7 cases of blood clots. I'm sorry, there were 6 of them. It was 7 million people. Obviously, it's a 1 in a million chance, so to speak. It's very, very low odds. But an independent advisory group to the Centers for Disease Control this week postponed making a recommendation about the continued use of the J&J vaccine. It looks like the current pause will continue until the panel gathers more information about the risk of rare blood clots and the connection with the vaccine. The Advisory Committee on Immunizations and Practices is saying that they can't yet make a decision about whether to continue these vaccinations since there's still not enough evidence about patients who experience the side effects. It's still a very difficult thing. Then why did you put a pause on it? Anyway, so these blood clots are obviously known as cerebral venous sinus thrombosis, which is accompanied by thrombocytopenia, which of course is going to promote clotting. These blood clots in women between the ages of 18 and 48 were located in various places in the body as well as in their brains. They mostly developed headaches 6 to 13 days after vaccination, but in and of themselves, they were not necessarily indicative of serious problems. But the thing that the CDC wants clinicians to know is that traditional treatment for clotting, in other words, using heparin, can actually make the condition worse. And this is why they put the big pause on things, stop in the name of don't cause more harm with heparin. So it's important to know that panel members do not think that the shot was necessarily dangerous or that the risks outweighed the benefits, but they're exercising caution until they have more evidence, which of course I agree. And you know, when I tell people, when I get asked about this, I'm like, listen, 6 people, 7 million jabs, that works out to be 0.0000088 risk of likelihood. That's where our regulatory bodies are, right? So this is a way that you can talk to your patients or people that if the risks are that minute, right? That minute, if that's the level of risk that we are actually putting a pause on things, you know, we've got a very, very tight regulatory system here when it comes to vaccinations. All right, so the panel will inform their decision about the shot. Ultimately, it's expected that, again, it'll last some days or weeks, but not months. And it's not clear what level of evidence the committee members want before they make any recommendations. While most of the committee members spoke, seem to favor the pause and were convinced that will reinforce confidence in the vaccine. Some did express frustration at the lack of action, as well as the impact a continued pause will have on vulnerable communities. And I actually share that opinion. And let's see what happens moving forward. I think that when we look back in the rearview mirror, where is it? Right there, the rearview mirror, on 2020, 2021, and hopefully, dare I say, not 2022. But when we look back on this, public health messaging is going to be such an important part of the lessons here. And I really do believe that moving forward in medical schools, we should be teaching communications and public health communications to everybody, because I think that hasn't happened in the past, and there has been somewhat of a fail as a result of that. All right, so let's talk more about vaccines. Let's talk about intranasal vaccines now. Now, of course, vaccines are awesome, and you know I'm a fan of them. Once the vaccine materials seep into the bloodstream, they begin to induce creations of antibodies. Watch out for my soon-to-be released animations. That's right, me, cartooned. It was very hard to see myself as an animation. I got over it, but we will have some animations to release soon that's going to explain how vaccines work. Obviously, all of you know this, but they're meant to be used with your patients. But anyway, so these antibodies, which of course circulate in the bloodstream throughout the body, and they protect, of course, the vital organs and, of course, create immunity. So now there's talk of a new intranasal vaccine that with spritz. So you see, spritz up the nose could potentially encourage the body to produce protective antibodies in the upper respiratory tract and neutralize the virus on its way before it makes the person sick. So as they get into the nasal cavity, they will be arrested right there. Now, it could potentially ensure that no live virus escapes when someone exhales, coughs, or sneezes. Right? No virus is going to escape. Their mucosal immunity is definitely promising. Companies are in early stage clinical trials, and an intranasal COVID-19 vaccine could still be a year out, and it could make a real impact in breaking the chains of transmission. So fingers crossed. Now, the existing vaccines achieve systemic immunity by sparing the production of antibodies. Watch my animation soon. It's going to explain it all beautifully. All right, these killer T cells are great at neutralizing the virus, which before seriously damaging our key organs are necessary to lock in place. So it makes sense that to prevent the virus from entering our body into the first place, we need to target the mucosal system. So enter secretory IgA antibodies, which exist in the mouth and the nose, and they're very potent against the SARS-CoV-2 virus than antibodies induced by intramuscular vaccines, and they're definitely a step up from protection offered by the existing vaccines. So 5, count them, 1, 2, 3, 4, 5. I think it needs to be the other way. 1, 2, 3, 4, 5. Anyway, there's 5 of them. Of these intranasal vaccine candidates are currently undergoing clinical trials. According to the WHO, there is belief that the best way to stop viral transmission is also by protecting the body from disease, and the intranasal vaccines are the only way to get mucosal antibody response because it provides localized immunity. Now, here's the bottom line, is that if the virus is unable to breach the mucosal and systemic immune systems, it cannot live and it cannot replicate in the nasal passages of the body. So great news. But intranasal flu vaccines like FluMist that have been around for quite a while, the CDC is not recommending them as much as previously so. And this is because this is in quotes, they've become variably effective against circulating flu strains, causing the CDC to revoke the recommendation for them for several years, and it's likely having to do with the fact that there's been significant mutations with influenza. Now, this has evolved. Thinking about vaccines is actually following the same path as the polio vaccine, which started as an intramuscular vaccine but evolved to be taken orally. And with that polio vaccine, it came in direct contact with gut mucosa to boost the mucosal immunity and stop infection and transmission. And this is how COVID-19 intranasal vaccine could work with mucosa. As an aside, stop me at the FACOI conference in San Francisco and ask me how my wife's grandfather was actually in charge of distributing the polio vaccine in the 50s and the 60s. He's an amazing man. I wish I met him, but we were just talking about polio vaccines. I figured I had to mention it. All right, so there we go. All right, so this intranasal vaccine will be likely available in early 2022. Fingers crossed, and may serve as seasonal revaccination, and this kind of effort will certainly help us deal with the virus becoming endemic in the human population, because ultimately, whether we like it or not, they are here to stay. All right, so now we're going to wrap this up, take this home, land this plane by answering some questions about vaccines, because vaccines rule, or the spray miss. I was interviewed for Vice just recently, yes, and I was interviewed about the most common vaccine questions that are still being asked. So one of those is, do I still need to get the vaccine if I've already had COVID? Of course the answer is yes, of course you need to be vaccinated, but know that you should wait 14 days after symptoms subside, or 90 days if you've received plasma treatment before getting that vaccine. So, okay, now the bottom line is that we don't know what level of immunity you may have had as a result of your COVID infection. Now, the fact is that you may have had a light antibody response that would potentially put you at risk for reinfection. So, the immunity that you carry from the previous infection can vary in effectiveness and how long you will remain immune, while the vaccine gives you pretty standard immunity response, which of course is a key step to reaching herd immunity and will prevent you from possibly being reinfected from further COVID strains. Okay, now evidence is mounting that vaccinated individuals are less likely to transmit COVID, which means that each vaccinated person is playing a crucial role in stopping the spread of coronavirus, and that's a good reason in and of itself to be vaccinated. People are also asking if it's really necessary to get the second dose of the vaccine, and my answer is yes, of course. Studies show that significant effectiveness after one dose, true enough, but after the second dose, that goes up to 90%, which is amazing. So people are also wondering why they have to get, why they have more severe responses to the second dose of the vaccine. Well, that's because each person is different. They'll have a different reaction to the shot, whether it's the first of two or the second of two. Responses vary. Now, evidence is showing that those who've previously had COVID-19 may experience a more severe reaction to their first dose, while those who haven't had may experience a more severe reaction after their second. All right, so there you go. Now, it's interesting how it works, but when your body sees that vaccine for the first time, assuming you were never exposed to the virus, it's the first time your body has ever seen that spike protein, right? The second time, your body's remembering it, and you react by making even a greater immunological response, and that robust response can lead to side effects that we hear about: sore arm, fevers, chills. I'm sure maybe you've even experienced it. All right, lastly, how important are vaccine cards? I say they're very important, so keep them safe. Better yet, take a photo of it, upload it to the cloud. Also, think about sending that image to your primary care physician so that it becomes part of your vaccine record. Also, consider putting it in fireproof safe or wherever you keep important documents. It's possible that vaccine passports may become a reality, and you may want to prove that you've had your COVID vaccine at some point in the past. All right, probably the most common question I get is, can I take Tylenol before my vaccine? There's a long story that goes behind it, but just to say for right now, consensus is don't pre-medicate. So you can tell your patients don't pre-medicate prior to getting vaccinated. However, afterwards, NSAIDs or Tylenol work just great. So I want to say thank you so much for Vice Magazine for featuring me, and thank you for the great Gina Kilker for keeping that part of the interview, putting that part of the interview here in this segment. All right, stay on the lookout for our regular updates, and to read more from the sources used in this report, go to the acoi.org/COVID-19. Together with the ACOI, we'll continue to have the latest information to keep you informed so you can respond to your patients, stay on top of the crisis. Please feel free to reach out to me anytime at madery@mac.com. Please stay safe. We can do this together.